to begin now with a discussion of prevention of first and recurrent stroke. Here are my obligatory disclosures, most of which have to do with being on various steering committees to help us further science. We will focus for this discussion of first and recurrent stroke prevention on some new guidelines that have come out from the American Heart Association, of which I've been involved in either writing the guidelines or in being a primary reviewer of them, and then we'll talk about some new data as well. These are the two guidelines for primary stroke prevention, just out this year, and for secondary stroke prevention, again, just out this year. So the first point that I wish to make, which I think is exceedingly important, as you can see here, stroke is not a homogeneous disorder. There are a number of subtypes, as you can see here, for ischemic and stroke. There's atherosclerotic large artery disease, small vessel lacunar disease, cardiac source embolism, non-atherosclerotic causes of stroke, and cryptogenic stroke. When we look for the cause and we can't find what was the underlying etiology, and we've turned these patients upside down, inside out with testing and don't find anything, and up to 20 to 30% of the time we don't find an obvious cause. The reason why I'm bringing this all up to you is that large artery high-grade occlusive disease, as you'll see, should have carotid endarterectomy or angioplasty and stenting. Cardiac source embolism, such as atrial fibrillation, should have anticoagulation. We must define the stroke subtype. So, what are the traditional risk factors for stroke? Well, they're not a mystery to this illustrious audience, as you can imagine. This is from the Inner Stroke study by Salim Youssef, and you can see here the good news is that 90% of risk of ischemic stroke was explained by 10 risk factors, most of which we can do something about and that you're familiar with, from cardiac disease, hypertension, being the crown jewel of risk factors, having the highest population attributable risk, meaning that hypertension explains almost 35% of stroke. So if you're a good doc in the trenches and you can treat hypertension well, you're going to be doing your patients a real favor. Other things such as current smoking, waist-hip ratio, poor diet, physical inactivity, and so on, all the usual things that we need to be treating. And I'm going to tell you a little bit later about why the doctors in the trenches are becoming the heroes of medicine, because some of the work that the docs in the trenches are doing right now are beating out the interventions and surgeries. So if you're a treating doc, good news for you and the patients. All right, the population attributable risk explains the percentage of risk for a particular factor that explains a disease. So the population attributable risk for hypertension, as I just showed you on stroke, is about 35%. So 35% of stroke may be explained by high blood pressure. And this is a calculation I did some years ago. Now there's almost 800,000 strokes, but you can see we could prevent almost 400,000 strokes if we could optimally treat hypertension in this country. Other factors, cholesterol, cigarette smoking, AFib, heavy alcohol use are also important factors, but pale in comparison to hypertension. So here's the good news. For recurrent stroke prevention, if we can intensively treat these factors, diet, exercise, use the right anti-platelet agent or anticoagulant, use a statin agent, use good blood pressure lowering, we can probably reduce the risk of stroke by some 80 to 90%. So again, treat carotid stenosis, AFib, diabetes, smoking, blood pressure, etc., up to 80 to 90% relative risk reductions for recurrent stroke prevention. Okay, so let's now get into the basics of the AHA guidelines for recurrent stroke prevention. I'm going to stick with recurrent stroke prevention from here on in because the topic is very large and we're going to need to focus down. So as I mentioned, hypertension is the key. We're telling people now you can initiate blood pressure control about 24 hours after an acute ischemic stroke to begin the recurrent stroke prevention process. And in the PROGRESS trial, what they used were ACE inhibitors and diuretics, though we're saying that you can use anything you want but get the blood pressure down eventually. In the PROGRESS trial, they reduced blood pressure by an absolute of about 10/5 millimeters of mercury, and they got very substantial risk reductions for recurrent stroke prevention. So if you have a patient who has ischemic stroke, and you want to reduce their risk of stroke, blood pressure lowering is one of the most powerful ways to do it. You can get as high as 42% risk reductions by lowering blood pressure chronically in the outpatient clinic. And even if you don't lower it a real lot, you still may be getting about a 25-26% risk reduction. Diabetes, we're recommending glycemic control with hemoglobin A1C targets of somewhere around 7%, but lipid and blood pressure control in our diabetics is exceedingly important for recurrent stroke prevention. We won't go into all these other factors because you're probably familiar with treating them and know most of the targets. But I want to call your attention to the ACCORD study. You probably have heard about it during this important meeting. There were 2 blood pressure lowering treatment groups, as you can see here. One had standard control, and they got systolics down to about 133.5 millimeters mercury in these diabetic patients. And then they had intensive control, which got down to about 119 millimeters of mercury. And the question here was, in these diabetic patients, if you intensively lower blood pressure, are you going to do better? And here's the answer from God's Journal, the New England Journal of Medicine, of course. And I know all you don't believe that, but anyway, here we go. What happened was the major outcome endpoints did not improve in this study except for one. And that one outcome endpoint is, let me get this other, see if I can get this to work here. Let's see. Well, here we go. There we are. Good. The major outcome endpoint is stroke. And so the stroke outcome endpoint here was statistically significant with intensive blood pressure lowering, but the others were not. Some question was raised, is there a danger of lowering the blood pressure too much in these patients? For stroke, it doesn't appear to be the case, but for heart disease, it may be the case. And so we're now recommending blood pressures for stroke prevention as low as you can get them within this range here. However, the problem is, can you pick out patients who are just at risk for stroke and not at risk for coronary disease? Because the coronary disease patients don't seem to have this benefit and could cause some problems for them in relation to the so-called J-shaped curve. So we'd like to get the blood pressure down. Every study shows that as you get the blood pressure lower and lower, your patients do better for stroke prevention, but the heart doesn't seem to tolerate this as well, as all of you know. All right, let's shift gears now from blood pressure to homocysteine. Our guidelines in 2011 for homocysteine lowering are that, yes, we can lower homocysteine with B-complex vitamins. The only problem is it does not lead to stroke reduction. Great hypothesis about homocysteine. We can lower it, but we don't reduce stroke risk, and this has been shown in multiple studies now, and many of them have been in the cardiac literature. VISP and this study, Vitatops, which was published recently, all show the same thing. You can lower it, but it doesn't reduce the risk of coronary events and stroke. Antiphospholipid antibody syndrome. This is a syndrome where people have venous and arterial occlusive disease in multiple organs. There may be spontaneous abortions. They may have livido reticularis of their skin. And these are patients who should be anticoagulated if they have the antiphospholipid antibody syndrome. However, we see a lot of patients who have cryptogenic strokes, as I mentioned, or TIAs. They have an antiphospholipid antibody, but not this full-blown syndrome of antiphospholipid antibodies. And in those cases, it is reasonable, if there's just one antiphospholipid antibody present, especially in low titer, to just use aspirin in those cases. All right, let's move now to the new antithrombotic agents and other medical therapy and interventions. And here's a picture that probably most of you haven't seen, because I've been in practice. I'm on my 30th year, and I've never seen one of these. So my good buddy Howard Kirshner at Vanderbilt lent me this slide from one of his cases. And this, of course, is a PFO with a clot streaming from the PFO. I order lots of echocardiograms. I support my cardiology laboratory. They love me. Okay, I'm one of the big users, or you may say abusers, of echocardiography studies. And so I've never seen this in 30 years. Of course, we more recently invented TEE to find more things. But anyway, let's talk about PFO. So what's the American Heart Association recommendations for recurrent stroke prevention? Very simple. In most of these patients, antiplatelet therapy, aspirin or clopidogrel, for example, will suffice. Warfarin is reserved, in our estimation, for people with underlying hypercoagulable states, DVT, pulmonary embolism, some very compelling indication. We don't know, according to these guidelines when they were first posted, if there was evidence to base a decision about PFO closure that was very good. So we didn't have good evidence at the time, though I'm going to show you a study that came out right afterwards in cardiology sessions at AHA that does answer the question. And in this guideline, we also say we don't know if anticoagulation is equivalent or superior to antiplatelet agents. Thus, we tend to err on the safer side and end up giving people antiplatelet agents who have PFO. Let me say that of this illustrious group sitting in the audience, probably about 25% of us will have a PFO. Now, I hope we're all not falling over and dropping dead of a stroke. You're all here, so apparently that didn't happen. So I highly question the issue of PFO as an etiologic factor in stroke. If everybody has one, or if 1 out of 4 of us roughly have one, how could it be that bad unless it's exceedingly complicated with a markedly redundant mitral valve or rupture of the choroid tendinae or AFib, which we rarely see in these patients. So I'm not sure it's etiologically attached to stroke, unless, of course, you have this picture, which is very unusual. Okay, so after the guideline was published online, this abstract came out. I've not seen the paper so far, and it's almost been a year now, of 909 patients who had cryptogenic strokes, and some of them were randomized to medical therapy. The others were randomized to Starflex closure device to get the PFO closed off. And again, I have to use this famous source, HeartWire, because there's no paper as of yet for me to quote from God's journal. No difference in the composite endpoint of stroke or TIA after 2 years. It didn't work. Closing them didn't do better or was not non-inferior to antiplatelet therapy or anticoagulation, whichever was chosen by the good old treating docs in the study. Didn't matter the size of the shunt or the presence or absence of atrial shunting. So this didn't look too good. There's a couple of other studies out there, but again, I am very, very skeptical about PFO, just as many of us were skeptical about mitral valve prolapse. Do you remember that one? In the 70s, that was going to explain all of stroke and everything else that ailed us. And guess what? Then we found everybody's got mitral valve prolapse or Barlow's syndrome. Okay, what about antiplatelet agents? Acceptable to use any of these 3: aspirin in a dose of 50 to 325 milligrams, aspirin plus extended-release dipridamole, 25-200 twice a day, or clopidogrel 75 milligrams per day. You can use any of these agents. Happy to discuss the details of which one you choose when we have the Meet the Professor sessions. What you don't want to do in stroke patients, unless there's a compelling indication such as a stent placement or acute coronary syndrome or some reason to use combination therapy with aspirin and clopidogrel, you don't want to use that in routine stroke patients because the risk of major and life-threatening bleeding goes up 2 to 3 times in these patients. And if you don't believe it from the MATCH trial, the SPS-3 study for recurrent stroke prevention and lacunar infarcts was stopped a couple of weeks ago because aspirin and clopidogrel were being compared to aspirin alone, and guess what? Too much bleeding with aspirin plus clopidogrel in the recurrent stroke prevention cases. So it keeps showing up in all the databases, plus it's not being shown to be more effective than aspirin or than clopidogrel alone. Okay, so here's a study. I thought I'd throw it in because it's a new drug called Tirutroban. It was compared to aspirin. It's what's called a TP, or a thromboxane prostaglandin receptor inhibitor, or an anti-platelet agent, and the results were 11% reduction of ischemic stroke, MI, or vascular death in people who had had a first ischemic stroke with Tirutroban, and 11% with aspirin. What we're saying here is it's tough to beat out aspirin, folks. Aspirin ain't so bad a drug when it gets compared to some of these other supposedly more potent or more effective platelet inhibitors. All right, let's move on to carotid endarterectomy. I'm going to show this picture twice. It's one of my patients, high-grade stenosis of the carotid artery, symptomatic. So what do you do with these patients? The best thing you can do is find an endarterectomist who has a very good track record and get a carotid endarterectomy done if they have 70 to 99% stenosis on the imaging studies. If you have 50 to 69% stenosis, you still benefit from endarterectomy, not quite as much, but you still benefit. It's a great procedure in the best of hands, and it seems to work better with this degree of stenosis, 50 to 69%, in men and in people who have a hemisphere TIA or minor stroke, rather than in women or those who have a retinal TIA or minor stroke. It still works in women, however, but you don't get quite as much bang for your buck as you do for men. Under 50% stenosis, forget about endarterectomy. Medical management, folks, that's the way to go. We're going to talk about carotid angioplasty and stenting in the next lecture I give, so stay tuned, please. All right, what about intracranial arteries? That's a major problem, especially in the African American community and Asian communities and some Hispanic communities. In fact, intracranial atherosclerotic disease is the most common cause of stroke worldwide. We think it's neck artery problems or cardiac source embolism. It ain't. If you go worldwide, intracranial occlusive disease is the most common form of atherosclerosis leading to stroke. Aspirin is the preferred drug. I'm going to show you some data that angioplasty and stenting doesn't work well for these diseases intracranially, and warfarin causes too much bleeding in these patients, and it takes warfarin out of the picture. So use aspirin. Here's the SAMPRIS trial. And for those of you who are treating docs and don't think you're making a difference in your practice, pay attention, please. This is exceedingly important. I say here, and I'm no disrespect to the surgeons in the crowd, intracranial stenting in the SAMPRIS trial was shot down and up with medical management. This is unbelievably remarkable. So here's the SAMPRIS trial. These were people with 70 to 99% intracranial artery stenosis, middle cerebral, carotid, those types of arteries. They were randomized to either the medical arm, which was really intensive medical management. They got those LDL cholesterols down. They got the blood sugars down. They got the blood pressure down. They were all over the investigators with lifestyle management to get those patients under control. And then everybody in the study got that treatment plus antiplatelet therapy. And then the other arm was all that stuff plus the wingspan stent intracranially to open up that 70 to 99% stenosis. So what happened? The study was stopped after about 60% of the randomization. Why? The medical arm beat the pants off of the intracranial stenting arm. Look at this here. Stroke and death, 14% for the wingspan, only about 6% for medical management. Medical management was 2 to 2.5 times better than stenting these patients. The people who did the stents were good people. They had to pass a high scrutiny test to be able to do the stents in the study. These were not rookies or early starters. These were experienced people. And they still could not overcome the medical management arm. So getting those blood pressures down, those LDL cholesterols down, really work. All right, so here's the Sampras New England Journal or God's Journal life table curves. If you like to see life table curves, you see the medical management arm here. They did a heck of a lot better, lower rates compared to the angioplasty and stenting arm. And guess what? A second study, same kind of thing. Medical management makes the difference. But this is a little different. This is our friend at UNC, Bill Powers, who recreated the extracranial to intracranial artery bypass trial, or ECIC bypass. You take the superficial temporal artery here, plug it into the middle cerebral artery, and people who have intracranial or high-grade carotid occlusive disease. In this case, all the carotids were occluded. They all had PET scans because the surgeons complained in the last ECIC bypass trial that the wrong patients were selected for the ECIC bypass. Powers said, I'll take care of that. They're all going to get a PET scan. So we're going to see what the oxygen extraction fraction is, the brain needing more oxygen and glucose. He proved that they needed it. They did the study. And here's what happened in the study. Look at the non-surgical or medical arm. No statistically significant difference from the surgical arm in reducing ipsilateral stroke. And why? It was medical management that made the difference. The medical management arm did so much better than expected from the time the study started till now, when we have all this advanced medical management, that the difference was nil. There was no statistically significant difference. So again, proving the point of the importance of getting those risk factors controlled for stroke prevention. Okay, what about atrial fibrillation? We've spent a long time, I'm in my 30th year of practice, and every decade we flip-flopped about paroxysmal AFib. Well, in the early 2000s, we finally figured it out. Yes, my friends, paroxysmal atrial fibrillation is a risk factor for stroke. We've confirmed it. So whether you have paroxysmal AFib or permanent AFib, if you're high enough risk on the CHADS-2 score, the CHADS-2 VAS score, whichever screening tool you want to use, you get warfarin. Once you hit a CHADS of 2 and above, you become high risk. So what if you can't use warfarin? Well, some people have tried aspirin plus clopidogrel. The trade-off there is more, guess what? Bleeding, and it sort of wipes out the efficacy advantage. So if you have a patient prone to gastrointestinal bleeding, for example, might not be a good candidate for aspirin plus clopidogrel if you can't use warfarin. We also added in this new guideline that if you have these real high-risk CHADS cases, 5 or 6 CHADS-2 scores, you better bridge them with anticoagulation. This question comes up in my practice every week. I'm getting a call from one of my older patients who's on warfarin and they say, "Doc, I'm getting a colonoscopy. The gastroenterologist wants me off the warfarin because they may be taking polyps off. Doc, I got to go get my teeth worked on. Doc, I'm having a biopsy of this or that. Can I go off my warfarin?" Well, here's the story. If these are high-risk folks, if you got AFib patients, beware, because you take them off that anticoagulation, they are at very high risk, relatively speaking, to go on to have a stroke. You stop anticoagulation in your AFib cases, they are at relatively high risk of having a stroke during that downtime, especially if they're in these high-risk categories. Whether there's a hypercoagulable phenomena or exactly what happens, there's rebound hypercoagulability or what happens, I'm not sure. This is not well studied, but there are enough case series that are large and reports in the neurologic vascular literature to tell you beware. So you got to be very cautious with these cases. I tell them, do you really need the procedure done? And if it's really indicated, then we go through all this rigmarole and we bridge them before, we bridge them after. But there are some new drugs that can help us. Let's move in that direction real quickly. Well, those of you who have a warfarin clinic that you work with or built into your office know it's a narrow therapeutic index drug. A lot of drug-drug and food-drug interactions. People have to have constant vitamin K intake if they like green leafy vegetables and so on. You got to do a lot of monitoring. There's always the worry in the back of our minds, if they start bleeding, there may be a threat of litigation. And the bottom line is that approximately half or more of these patients who we think should be on anticoagulation with warfarin never get on it. So there's a whole group of people out there who should be on it but don't get it. And so is there an answer to that? Well, yep, here's dabigatran, a direct thrombin inhibitor approved by the FDA at 150 milligrams twice a day. And not only was it non-inferior to warfarin, but you can see based on this curve here of the high-dose dabigatran, the 150 dose, it was also superior. And to beat warfarin out or be superior is saying a lot, because warfarin by itself reduces the risk of stroke by some 60 to 80%. If you can be superior to warfarin, it's pretty good. The 110 dose, in the wisdom of our FDA, was not approved, even though it has a better safety profile than the 150 dose. It was not superior in efficacy, it was only non-inferior, which again is still a big deal in my mind. And the great news, hemorrhagic stroke, which we're all worried about, intracranial brain hemorrhages with warfarin, there were 3/4 less brain hemorrhages with dabigatran. So that is really good news. Rocket AF, rivaroxaban, yesterday approved by the FDA for use. This is a different group of people. Their CHADS-2 scores in the rivaroxaban study were higher at 3.5. Their range in their therapeutic time in range with warfarin, however, was lower than the RELY trial, where they got into the 60 to 65 range. These guys were only around 55 or so. The drug given one time a day, which is a huge advantage, was only non-inferior for stroke prevention. It didn't reach superiority. It had a better mortality profile, fewer deaths, and it also had less intracranial bleeding, as dabigatran did. So Rocket AF showed rivaroxaban, and this is a direct 10A inhibitor, where dabigatran is a direct thrombin inhibitor. Rivaroxaban was non-inferior to warfarin, but not superior. There was no significant between-group difference in the risk of major bleeding, although intracranial and fatal bleeding were less frequent. So we're seeing that trend or pattern with these newer drugs. Finally, Aristotle, the apixaban, another direct 10A inhibitor. Again, another one of these really large studies. CHAD scores similar to that of the dabigatran story, about 2.1. high therapeutic INRs, 66% of the time, and the data is very similar to the dabigatran story. This drug, like dabigatran, given twice a day. Apixaban was superior to warfarin, caused less bleeding, resulted in lower mortality. So this drug is not available yet. They're going to the FDA, where rivaroxaban was approved yesterday, and dabigatran has been on formulary for about a year now. So I will stop there, and I thank you very much.